Good afternoon, everybody. My name is Matthias Löhr, and I'm the General Secretary of the European Pancreatic Club. This is a very special session because we honor the lifetime awardee for the European Pancreatic Club. It is my pleasure to introduce to you Peter Ditsche, who is from the Czech Republic, and I indeed have a history with him, because after his graduation and his studies, did he join the Department of Gastroenterology at the University of Rostock in the 70s already. Now, I wasn't obviously there at that time, but my later boss, Stefan Liebe, held high esteem of Peter Ditsche and always said, we must not forget our pancreatologists, our friends from the East. So I was very happy when Natalia Gruber-Grips, the president of EPC this year, proposed Peter Ditsche to be the awardee of the EPC Lifetime Award. Among the many contributions which Peter Ditsche has done in his life, several stand out. The one which I think, for me at least, is one of the best is a prospective study where he compared endoscopic therapy and surgery in patients with chronic pancreatitis, published in Endoscopy in 2003. He also did attend several other subjects within pancreatology, amongst them the fatty pancreas. And this is what he's talking about today. So please, Peter, it's an honor to have you with us, and the floor is yours. Thank you.
Thank you, Matthias. The President of European Pancreatic Club, Professor Natalia Gruber-Grips, the Secretary General of European Pancreatic Club, Professor Matthias Löhr, dear colleagues, dear friends. It's a great honor for me that European Pancreatic Club has given me such distinguished award as this European Pancreatic Club Life Award. Thank you again for this award, and allow me wish you to all good health and greatest possible joy in the field of pancreatology. My presentation is focused to the history of non-alcoholic fatty pancreas disease. Historically, the first publication about the fat in the pancreas was published in 1933, that pancreatic fat is higher in obese individuals. 45 years later, the other presentation clearly documented the pancreatic fat increase with the age. And later on, absolutely important fact was presented by Stem and colleagues that presence of more than 25% fat in the pancreas is associated with a general atherosclerosis. And the role of obesity was published by Ginen and colleagues, and insulin resistance between the adipocytes infiltration causing the pancreatic steatosis, and the peripheral analysis was quite new result. Etiology of pancreatic steatosis is multifactorial. Age, obesity, and metabolic syndrome, extremely important. Diabetes mellitus, malnutrition, congenital syndrome with cystic fibrosis, Johansson-Bizarre syndrome, viral infection, and medication are most important etiological factors in pancreatic steatosis. Nomenclature of pancreatic steatosis is interesting. Non-specific terms for fat accumulation in pancreas is his pancreatic lipomatosis, pancreatic steatosis, or fatty pancreas. But much more precise definition is fatty replacement. It's mean destruction acinar cells and replacement the cells with adipocytes. Fatty infiltration is filtration with adipocyte due to obesity, non-alcoholic fatty pancreas disease. It's a topic of my presentation. Is obesity and metabolic syndrome and their role in the fatty pancreas, and non-alcoholic steatopancreatitis is something similar with non-alcoholic steatohepatitis. It's mean pancreatitis due to pancreatic fat accumulation. If you see this, the pathogenesis, as I mentioned, you see some diseases. We can speak about them primo moments, with the damage of the pancreatic tissue, with the necrosis and replacement this necrosis by fat. Lipomatosis of the pancreas or pancreatic steatosis is well known in the histological picture. Most important factors of non-alcoholic fatty pancreas disease is the obesity and metabolic syndrome. But also in experimental setting, maternal obesity and obesogenic diet leads to non-alcoholic fatty pancreas disease induction. How can obesity lead to ectopic fat accumulation? We don't know. But important fact is that the lipodystrophy, so-called the Bardet-Biedl syndrome, in healthy individuals with high subcutaneous content of fat have a low level of visceral and ectopic fat. This means probably that subcutaneous fat has some protective effect in ectopic fat accumulation. Transplantation of the normal adipose tissue in the subcutaneous region of lipotrophic mice removes their excess ectopic fat and insulin resistance. Non-alcoholic fatty pancreas disease is a very frequent clinical entity. It's so frequent entity as is frequent are obesity and metabolic syndrome, and we know that is the diseases of our population. Intrapancreatic fat is located, it's very important, within the adipocytes. It's usually spares to acini and isolate of Langerhans, preferentially located in pancreatic interstitial septa. Clinical consequences are extremely important. We know that non-alcoholic fatty pancreas disease is connected with endocrine dysfunction, exocrine dysfunction, diabetes, also cardiovascular diseases, metabolic syndrome, acute pancreatitis, non-alcoholic fatty liver disease, and pancreatic cancer. Generally, metabolic syndrome is the high risk of diabetes mellitus type 2, cardiovascular disease, stroke, and myocardial infarction. Non-alcoholic fatty pancreas disease are connected with beta cell dysfunction. Probably there are three hypotheses. Probably in the increased amount of triglycerides in pancreatic beta cells, or intrapancreatic adipocytes has a negative paracrine effect on beta cells. And the third is non-alcoholic fatty pancreas disease and diabetes mellitus type 2 as consequences of obesity. In theory, pancreatic steatosis can lead to exocrine pancreatic insufficiency via different mechanisms, fat accumulation at inner cells and consequent lipotoxicity, negative paracrine effect mediated by adipocytokines, and death of acinar cells as an effect of the exocrine pancreatic insufficiency and fatty replacement. Interesting paper was published in 2018 by the group from Turkey, and they examined the exocrine pancreatic function according to the estimation of the fecal elastase level. And the results was quite clear. Pancreatic elastase 1 significantly slower in patients with pancreatic steatosis than in control group. And as I mentioned, it was statistically significant. This means that pancreatic steatosis is co-exocrine pancreatic insufficiency. Pancreatic fat accumulation associated also with subclinical atherosclerosis, so it's a high risk of cardio or vascular events generally. In patients with non-alcoholic fatty pancreas disease, carotid intima media thickness is much higher, statistically significantly higher versus control in both sides, left side, right side is the same, but the changes are significant. Very important paper was published by a colleague from France, Professor Boers, that pancreatic fat infiltration is also the important factor in pancreatic intraepithelial neoplasia. It's mean in precancerous lesions. In pancreatic cancer, the degree of the pancreas fatty infiltration is positively associated with pancreatic ductal adenocarcinoma. It means that pancreatic fatty infiltration produces possible risk for the pancreatic ductal carcinoma, adenocarcinoma, independently of obesity and diabetes mellitus. Prediabetes and diabetes mellitus type 2 in non-alcoholic fatty pancreas disease, probably there is the important fact that the accumulation of fat in pancreatic tissue possibly initiates a vicious cycle of beta cells and deterioration of further pancreas fat accumulation. Probably there is an important role non-alcoholic fatty pancreas disease in development of prediabetes and diabetes type 2. In diagnosis, we use usually the imaging method because the biopsy of the pancreas is, from the clinical point of view, it's very, very difficult and complicated. Transabdominal ultrasonography, endoscopic ultrasonography, computed tomography, and magnetic resonance imaging are the methods we are frequently used. Typical sausage-like pancreas, hyperdensity, and the rim under the capsula is the picture which we can see in patients with pancreatic steatosis. The other, this is from our department, radiology department, steatosis of the pancreas. And what is important is that the pancreatic duct is, the diameter is very, very small. And there is the other picture, focal pancreatic fat infiltration in the pancreas, in the head, and in the body. The treatment of the non-alcoholic fatty pancreas disease, the goals is minimizing the pancreatic fat accumulation, certainly. We can start with diet, weight loss. Generally, we can say about the lifestyle modification, but also some drugs. These drugs are important, the obesity drugs, orlistat, or telmisartans. Surprisingly, it's not effective metformin, but most effective therapy is the bariatric therapy, bariatric surgery, or endoscopic therapy. Ladies and gentlemen, allow me conclude this my presentation about the non-alcoholic fatty pancreas disease. It's no doubt that pancreatic steatosis is a very important common condition. Pancreatic steatosis can be a marker of ectopic fat accumulation and insulin resistance in metabolic syndrome. Pancreatic steatosis can be a prognostic or predictive marker for acute pancreatitis, pancreatic cancer, or cardiovascular diseases or liver steatosis. And pancreatic steatosis is a possible cause of unexplained exocrine pancreatic insufficiency. According to my opinion, pancreatic steatosis is a huge clinical challenge, not only pancreatologists, also for internists and surgeons. Thank you for your attention.
Thank you very much, President. That was enlightening. Now, normally we do not discuss the lifetime awards. I would like to have another announcement. It was an unanimous decision taken by the Council of the European Pancreatic Club to award another lifetime award this year, not only to you, but also to our president, Natalia Guber-Gritz. Now, both Peter and Natalia, you're more than welcome to come to the next EPC meeting in Germany, München, Alpbach, for receiving these awards personally. Unfortunately, this is nothing we can do about today. Thank you very much again. And I think I have to close the session now and leave the floor to the next symposium in the program of EPC. Thank you very much again.
Jak se mě